Hi, everybody. I'm Brittany Lewis, a breaking news reporter here at Forbes. Joining me now is my Forbes colleague, senior editor Alex Knapp. Alex, thank you so much for joining me.
Always great to be here, Britt.
You are my go-to for everything healthcare related, and there is a lot of healthcare related news this week, so I want to dive right into it and get your expertise here. First, let's start on Monday. President Trump signed an executive order around drug prices. He's asking pharmaceutical companies to lower the prices of their drugs, and he said that this could reduce costs for prescription drugs of up to 30% to 80%. Can you talk to us first about what exactly is in this executive action?
Sure. I'm going to pull out a little Shakespeare here in that there's a lot of sound and fury signifying nothing in text of the executive order itself. What it does, in essence, is he wants to tie the cost of prescription drugs to what people pay in other developed nations, particularly Europe, where the cost of a lot of drugs are significantly lower for a wide variety of reasons. For one, their national healthcare systems negotiate for those prices, and Medicare, except for certain exceptions, is prohibited from negotiating for prices. That's one big reason for that. But there's not a lot of mechanism of action to actually make it happen. So the Department of Health and Human Services and its subsidiary agencies have to set targets, which they're going to ask the pharmaceutical companies very politely, I guess, to meet. If they don't meet those goals, then the Health and Human Services Secretary right now, Robert F. Kennedy Jr., would, be asked to start a regulatory process to kind of make this happen. The challenge there is that there's no actual law that would give the authority to HHS to actually negotiate drug prices. In fact, the Trump administration tried to do this the first time around, during its first term, and the courts blocked those efforts on the grounds basically that there wasn't any legislation, as well as a few other things besides.
I want to talk exactly why high drug prices seem to be a uniquely American problem. Because when you talk to other people from other countries, they are just shocked when they learn just how high Americans are paying for prescription drug prices. And in 2024, the organization RAND found this, that drug prices in the United States are over 270% higher than drugs in other countries. So why are drugs in the United States so much higher than anywhere else?
So there's a wide variety of reasons for this. Part of it is that the drug companies often, like I said, they negotiate prices with national healthcare systems. The United States, of course, doesn't have one apart from Medicare, which does not negotiate the price of drugs. And so in some sense, the pharmaceutical companies kind of make up a little bit of some of the money that they're missing out on with some of those negotiated prices. There's a little bit of a free rider issue happening. The other complicating factor is that health systems and pharmacies also add to the cost of drugs. And in particular, a lot of the eventual price that like you or I pay for a drug is done by what are called pharmacy benefit managers, who work on behalf of insurance companies and payers to kind of set the price of drugs. There is a real lack of transparency into how these people, how these organizations actually set the price of drugs. I remember I interviewed someone who he started up his own PBM that wanted to provide drugs less expensively. And he said that he'd been studying PBMs for something like 10 years, and he still didn't know exactly how they worked or how they got to the price of drugs. So, it's complicated, it's opaque, and that contributes to it. Now, there is bipartisan legislation to kind of rein in these middlemen, these pharmacy benefit managers, and to add more transparency to the price of drugs. And when asked about reducing drug costs, Senator Chuck Grassley, for one, a Republican from Iowa, kind of pointed to his PBM legislation as being a better way to do it than kind of tying the price of drugs elsewhere. The other thing you got to keep in mind is that the United States is also a richer country than everyone else. Like per capita, our income is significantly higher than a lot of other countries. And so in some way that the price is somewhat progressive in that we're paying more because we can afford to pay more. And you could argue that that's maybe how it should be. You could also argue that it shouldn't, however you want to see it. But a statistic I like to throw out is that if you made Great Britain a state of the union, it would be the 51st uh, poorest state, poorer than Mississippi. Like, we're just a really rich country and we can kind of afford to pay more. That's another part of it.
Another component of it could be that drug makers have huge lobbying power in DC. Is that something that you see in your reporting?
Oh, that's absolutely the case. I mean, certainly, it's bipartisan, and the drug companies definitely hold a lot of sway in DC, and I suspect they'll be fighting against any proposal to introduce legislation to kind of make this policy a reality and make it something that can be implemented legally. I expect anything that tries to happen with this to be fought in courts. It'll definitely be a real battle, I think, to bring costs down in this way.
And the title of your newsletter was Trump's drug pricing executive order is more bluster than substance. And as you noted, he tried doing this in his first term. That failed to happen. Do you think that we're going to see something really materialize where we're seeing a substantial reduction in the prices of drugs in this country based on this executive order alone? Because as you said, congressional approval, congressional legislation is also needed here.
Yeah, there's one interesting subset of this is that the text of the EO does seem to provide an incentive for drug companies that reduce their price when they sell directly to consumers. And this is something that drug companies have been experimenting with in a kind of very limited way. I think most notably that Lilly, for example, sells its GLP-1 drugs, particularly Zepbound, which is for weight loss. They have a program to sell that directly to consumer, which is something that they started up a few months ago. That has seen some real success as a way to get the drug more inexpensively if your insurance doesn't cover it, and a lot of folks' insurance doesn't. And there is an incentive to do that. So you might see as a result of this some programs geared around more direct consumer sales directly from drug companies instead of going through pharmacies. That would be kind of interesting. You also may see the kind of thing where you see some symbolic actions. So you saw with like domestic manufacturing, some companies made a big deal about bringing some manufacturing back home or expanding domestic manufacturing. They plan to do it the whole time, but they'll make a show of it to make the administration happy. And as long as there's a show of it, the administration seems to be happy. So it's kind of a win-win that way.
An argument maybe perhaps for these high drug prices is that if you lower them, that could stifle innovation. Does this executive order do anything regarding innovation in the healthcare space? Will we see less innovation with drugs, do you think, if prices are lower?
It is a real possibility. So one thing you have to keep in mind with talking about drug development is from start to finish, from the very start of the development process to the very end, only about 10% of drugs actually make it to market. But drug companies still spend hundreds of millions, even billions of dollars on drugs that fail. And those costs have to be recouped for the businesses to keep going. And so if you were to lower prices and you were to lower margins accordingly, I think, you certainly still see drug development, but you see a lot more Me Too development. You'd probably see more like refinements of current drugs. You'd probably see more like this drug's already approved for X, Y, and Z cancer. Let's see if it works for A, B, and C cancer as well. But you'll probably see less innovation in sense of riskier drugs or things that are untried or targets that are untried. You'd probably see less spending towards those, particularly with the president's budget wanting to cut basic research and other things. So that's where you get kind of a ripple effect here is with the NIH cutting funding to basic research, even cancer research. You're going to, see fewer ideas being tested in the lab to even get to the drug development part in the first place. So yeah, that the combination of these things could definitely result in less innovation. It's a real trade-off.
I want to now pivot a bit, and you did a perfect segue for me, so thank you very much, to President Trump's agenda. He wants to pass this, what he calls this one big, beautiful bill. House Republicans want to jam that through. They're tasked with finding cuts here, and the Energy and Commerce Committee specifically was tasked with cutting hundreds of millions of dollars. And the way the math was adding up, it seemed that Medicaid was really on the chopping block. And House Republicans I talked to, a lot of them said, we're not touching Medicaid, we're not touching entitlements. All we're doing is finding out and weeding out the waste, fraud, and abuse. But it seems like there's going to be some significant cuts to Medicaid. Talk to us a little bit about that.
Yeah, so right now it definitely seems that there's going to be significant cuts. Probably on the order of, we're talking double digit cuts, so the numbers aren't final, but, around 20%-ish, kind of phased in over the next few years. There's some real savvy dates in the budget. Some of these things don't take place till after the midterm election. Some of them don't take place until after the next presidential election. So I think there's definitely some concern for fallout from some of the impacts of these cuts that the folks in Congress are keeping in mind. There was an estimate by the Congressional Budget Office that the end results of the cuts to Medicare would probably result in about 13.5 million more people being uninsured over the course of the next decade than would have been the case otherwise. That's bad not only for the people who are uninsured, it actually causes an increase of costs overall. So when people don't have health insurance, they don't have health coverage, they're not going to the doctor for some of things, which means that the first time they encounter the health care system when they have a problem is going to be in the emergency room, which is significantly more expensive, results in hospitalization, which is significantly more expensive. So it's kind of like bragging that you cut your household budget by not doing, we're not going to do our car maintenance every 3 months anymore. We're going to save a couple $100 every few months, but then your car breaks down and you end up spending a lot more. That's kind of what the end result of some of these cuts may end up being.
And I think you and I have talked about before about the unintended consequences. And that's what I've been seeing a lot. Not only the impact of the millions of people who are going to lose their coverage, but also the impact on the people who still have coverage. I mean, what does this do to premiums? What does this do to healthcare costs overall for people who still are insured?
Yeah, that's a great question. Of course, some of the details are still being negotiated. They're not all out yet. One thing is that looks like there will probably be an increase in cost sharing from patients. And yet, remember, when people are on Medicaid, it's already because they don't have a lot of money or they can't work. So that's going to be a burden there. It's also probably going to be asking the states to put in more money. A lot of state budgets are already overburdened. The upshot of this, when you look at some of the analysis coming out from the nonprofits that are studying these and doing the analysis, is that there's probably going to be fewer services that are covered and some restrictions on eligibility and who will be, allowed to enroll in Medicaid on the state level. That is controlled on the state level. And one real place where you might see some cost to this is you got to remember, again, over 70 million people get their health insurance through Medicaid. In particular, a significant number of births are covered on Medicaid. So pregnancies, so we may see more complications to pregnancies. We may see more issues, involving miscarriages. We may see increases in infant mortality. And not only because people aren't getting coverage, but also a lot of rural healthcare systems kind of depend on, these Medicaid payments to keep going, to keep their operating costs. A lot of rural hospitals are in the red. This could put them more in the red. We've already started to see like maternal care and other kind of inpatient services like for mental health and other things being shut down. And it's just going to mean that for people in rural areas in particular, they're going to have fewer resources, fewer options to take care of their own health.
And as you and I sit here right now, this one big beautiful bill, as President Trump calls it, it hasn't even made its way to the Senate yet. But based on what you see now, based on the details that are coming out now, how exactly does this change the landscape of healthcare in this country? Do you think it's dramatic? Do you think it's more muted? What do you make of that?
That's a great question. I have real questions over whether a lot of these cuts will survive the Senate. There seems to be a lot more opposition among Republican senators to a lot of these provisions. So I do think even the House version that we see now is muted from what was being floated a couple of weeks ago. We've definitely seen some reductions in some of the proposed cuts and other things. I suspect that we will, as it goes to the Senate, we'll see even further reductions in cuts. And I do think that probably one, it'll probably be less, we probably won't see a worst case scenario. I do think that the Senate negotiations are going to blunt a lot of the impacts of some of these things, especially as more state legislators and governors start lobbying as well. And people, again, worried about their midterm elections and other things. So, it really depends. I think part of weirdly enough where the battle may going to happen is how many of the tax cuts that the administration is proposing end up going through. You may see that the bond markets are really opposed to the tax cuts and implement right now. Bond vigilantes kicked Liz Truss out of office in the UK when she tried some really significant unfunded tax mandates. So it's a real question of whether tax cuts or spending cuts to Medicaid win out overall in terms of reining in the deficit. So that's the interesting battle to watch.
And if we remember, I don't think Liz Truss's tenure was as long as a head of lettuce was ripe. I mean, that was the ongoing joke there, and she didn't survive over that. But I do not want to ask you, HHS Secretary Robert F. Kennedy Jr. did testify before lawmakers this week. As an editor in the healthcare space, what piqued your interest? What stuck out to you?
Well, I think the primary thing that stuck out to me is that it left me wondering if the secretary is entirely knowledgeable about what's going on in the subsidiary agencies in HHS. So, he got questions from senators and in the House about, staffing cuts impacting cancer research, about people being kicked out of clinical trials. And he kind of denied that any of these things were going on, saying that, no scientists have been fired, that nobody had been kicked out of a clinical trial who should have been in that clinical trial. But there's a significant amount of evidence reporting to suggest that that's simply not the case. And so it makes you wonder, how aware is he of what his own agency is doing? And he also, I'm not sure, one thing that was interesting to me is I'm not sure how into some of these cuts he was. He kind of said that as secretary, he has to defend the administration's budget, but he didn't seem particularly happy about how badly the cuts are impacting his own agency. I give him credit for one thing is that he did admit to some mistakes that have been made and some of the Doge cuts and others that have been subsequently reinstated and owned up to them. So credit where credit's due there, but it was certainly a very combative thing. And I think he's still left senators and representatives alike with a lot of unanswered questions.
And I think something that really sparked social media's interest for sure is he said something to the effect of, "Don't get your medical advice from me." I mean, he's the HHS secretary. Before him, I mean, is that unprecedented for an HHS secretary to basically say, "Hey, I'm not the guy for medical advice"?
Yeah, I mean, it certainly is. Part of the role of HHS, this is the agency that oversees the CDC, the FDA, and the NIH, any number of healthcare industries. And a big part of public health is, providing advice and providing, a base of knowledge that people can rely on to protect their own health. And so to say, I'm not the guy to get advice from, to me, really felt like an abdication of responsibility. But also, given that he also has a history of disseminating some medical information that turns out not to be true, I also maybe kind of agree with him on that point. So there's the paradox there.
Well, Alex, I know that healthcare in this country is going to be a major talking point as this budget goes through, as we see more actions from the Trump administration. And I hope you can come on, make sense of them with us. Thank you so much for joining me. You are welcome back anytime.
Great, thanks. I'll be happy to come back.